Hello, I'm Dr. N.S. Mani. In this series of video, I'm dealing with the ECG analysis of pediatric patients. Use the pause button and play button to control the speed of the video streaming if it is too fast. This picture shows the vertical and horizontal perspective of the leads. The limb leads view the heart in the vertical plane and the chest leads view the heart in the horizontal plane. You can see the vertical plane from your right side in the clockwise direction. It is lead 1, 2, 3, and the 3 leads are numbered in English alphabets as AVL, AVF and AVR. So altogether there are 6 leads: 1, 2, 3 AVR, AVL and AVF in the vertical axis. And the horizontal axis you can see conventionally 6 leads: V1, 2, 3, 4, 5 and 6. In addition, you can take the right sided leads like AVR 3, 4, 5, 6 and V7, 8 and 9. About these descriptions I have already told in one of the previous videos. Now the position of the 6 chest electrodes for standard 12 lead electrocardiography is shown here. The V1 shows the right sternal edge, the 4th intercostal space. V2 means left sternal edge, 4th intercostal space. V3 means between V2 and V4. V4 is in the mid-clavicular line. V5 mid-clavicular line, the 5th space is V4. V5 means anterior axillary line, horizontally in line with the V4. V6 in the mid-axillary line, horizontally in line with the V4. Now the picture shows wave of depolarization. Shape of QRS complex in any lead depends on the orientation of that lead to vector of depolarization. The big arrow shows the wave of depolarization from negative to positive. If it is flowing, you will get the deflection as shown in the right side. That's a positive wave. Whereas on the left side, you can see it is a full negative. Whereas in between there are 3 more leads shown where there is biphasic deflection. So depending on the wave you see, you have to imagine the wave of depolarization as shown by the arrow. The second picture shows the His-Purkinje conduction system, about which also some details have been already given in one of the videos. The picture shows the right atrium containing the SA node. The left atrium as such doesn't usually have a natural source of electrical activity, but in pathology it can be an origin. Then at the lower part of the right atrium you can see the atrioventricular node, then the single conduction path downwards through the electrically inert atrioventricular region. It is in this part an accessory pathway develops. You get WPW syndrome and tachyarrhythmias, which occurs commonly in Epstein's anomaly. Then the bundle divides into 2 parts in the septum, left bundle and right bundle. And on the left side you can see the left anterior hemifascicle and the left posterior hemifascicle, which are important in diagnosis of fascicular blocks. So this anatomy should be understood very well to understand how the ECG changes are described in various bundle branch blocks, nodal blocks atrial tachyarrhythmias, ventricular tachyarrhythmias, which are partly dealt with in one of the video sessions on how to interpret the adult ECG. You can visit them in the www.youtube.com/ACEPGMed. The third panel seen in this frame is showing the various axes. They are numbered 1, 2, 3 AVR, AVL and AVF, and between two adjacent axes you can see the angle is around 30 degree, and the total 12 leads make it is 360 degree. So the lower half is plus 180 and the upper half is minus 180. So the important point is that positive lead of 1 is 0, that of 2 is 60, and that of 3 is 120. That means positive deflection if seen, 1 it is 0, 2 means it is 60, and 3 means it is 120. If you see positive deflection in AVF, it is 90 degree. The AVR shows if positive means it is in 150 minus, it is minus 150, and if there is a positive deflection in AVL, it is minus 30. So if you want to get the negative angle, the difference between 180 and the angle will give that. For example, if it is 60 plus in 2, that means 120 minus. In other words, if you see a negative deflection in lead 2, it means it is minus 120. The details will be shown in one of the examples, which will be covered in another video session. And this frame I am showing you the standard calibration signal, speed of 25 mm per second, and the voltage of 10 mm showing 1 millivolt. Anatomical relations of lead in a standard 12 lead electrocardiogram: 2, 3 and AVF are related to the inferior surface of the heart. V1, V2, V3 and V4 are facing the anterior surface. Lead 1, AVL, V5 and V6 represent the lateral surface. V1 and AVR shows the right atrium and cavity of the left ventricle. The cardinal features of sinus rhythm are that the P wave is upright in lead 1 and 2. Each P wave is usually followed by a QRS complex, and heart rate is usually between 60 and 99 beats per minute in a older child or an adolescent, but the rate may be a little higher in an infant and a newborn. The age appropriate values you can refer from standard textbooks. What are the characteristics of P wave? It's usually positive in lead 1 and 2. It's best seen in lead 2 and V1. It's commonly biphasic in lead V1, and usually less than 3 small square in duration, less than 2.5 small square in amplitude. Non-pathological cues are often present in lead 1, 3, AVL, V5 and V6. And in the lower panel, I am showing the typical change in morphology of QRS complex from lead V1 to V6. The transition shown is shown there. That is, V1 is mainly showing the QRS negative, whereas V6 is mainly showing QRS positive. Whereas between V3 and V4, you can see that the negative deflection becomes positive. That is done by transitional zone. And in this picture, I am showing the ST segment should be in the same horizontal plane as the TP segment. The J point is the point of inflection between the S wave and the ST segment. The QRS complex terminates at the J point or ST junction. The ST segment lies between the J point and the beginning of T wave, and represents the period between the end of ventricular depolarization and beginning of repolarization. The change in ST segment morphology across the precordial leads is shown in the right panel. You can see the ST segment should be level with the subsequent TP segment and is normally fairly flat, though it may slope upwards slightly before merging with the T wave. Some examples are shown in the V2, V4 and V6 leads. In leads V1 to V3, the rapidly ascending S wave merges directly with the T wave, making the J point indistinct and the ST segment difficult to identify. This produces elevation of the ST segment, and this is known as high takeoff. Non-pathological elevation of the ST segment is also associated with benign early repolarization. That is mentioned in one of the videos in the acute myocardial infarction earlier in the series, which is particularly common in young men, athletes and black people. Interpretation of subtle abnormalities of the ST segment is one of the more difficult areas of clinical electrocardiography. Nevertheless, any elevation or depression of the ST segment must be explained rather than dismissed. The complexes in lead V2 and V3 showing high takeoff is shown in the left panel, and the change in ST segment morphology across the precordial leads is shown on the right panel. The T wave should generally be at least 1/8 but less than 2/3 of the amplitude of the corresponding R wave. The T wave amplitude rarely exceeds 10 mm. And in this picture I am showing the right bundle branch block showing the wave of depolarization spreading to the right ventricle through non-specialized conducting tissue. Bundle of His divides into right and left bundle branches, and the left bundle branch then splits into anterior and posterior hemifascicles, which I already told you. Right bundle branch block. In most cases, right bundle branch block has pathological cause, though it is also seen in healthy individuals, sometimes rarely. When conduction in the right bundle branch is blocked, depolarization of the right ventricle is delayed. The left ventricle depolarizes in the normal way, and thus the early part of the QRS complex appears normal. The wave of depolarization then spreads to the right ventricle through non-specialized conducting tissue with slow depolarization of the right ventricle in a left to right direction. As left ventricular depolarization is complete, force of the right ventricular depolarization are unopposed, thus the later part of the QRS is abnormal. The right precordial leads have a prominent and a late R wave. The left precordial lead, limb and limb leads have a terminal S wave. These terminal deflections are wide and slurred. Abnormal ventricular depolarization is associated with secondary repolarization changes, giving rise to changes in the ST waves in the left chest leads. Diagnostic criteria for right bundle branch block are QRS duration equal to or more than 0.12 second, secondary R wave or R dash in V1 or V2, wide slurred S in lead 1, V5 and V6. Associated features are ST segment depression and T wave inversion in the right precordial leads. Left bundle branch block is most commonly caused by coronary artery disease, hypertensive heart disease or dilated cardiomyopathy. It is unusual for left bundle branch block to exist in the absence of organic disease. Left bundle branch is supplied by both the anterior descending artery, that's a branch of left coronary artery, and the right coronary artery. Thus, patients who develop left bundle branch block generally have extensive disease. This type of block is seen in 2 to 4% of patients with acute myocardial infarction and is usually associated with anterior infarction. The diagnostic criteria for left bundle branch block: QRS duration equal to or more than 0.12 second, broad monophasic R wave in lead 1, V5 and V6, absence of Q wave in lead V5 and V6. The remaining part of the session, including left branch block, will be dealt in the subsequent videos. Please visit youtube.com/ACEPGMed. Thank you.